Just to acknowledge all the senior people and Dr. Bhavna for having put this talk together. I'm going to cover contact lens associated ocular emergencies and complications. Any person wearing a contact lens, and this is important, the general public or people who wear contact lenses, they take it like a very common and a casual thing, and they're not that careful. So if any time you're prescribing contact lenses to a patient, it's very important to counsel them and educate them that it can be a double-edged sword and can lead to many serious complications. Contact lens associated ocular emergencies. Here again, often the patients, they are, despite all the counseling and education, they often, particularly they're very young, they're students, very busy and not able to take care of the proper hygiene, etc. They can sometimes land up in serious problems. Now, what are the components which are responsible for the complications? One is, of course, there could be physical or physiological factors which could be related to the fit and condition. This is a little bit rare because usually the contact lens practitioner would have taken care of all these issues at the time of fitting itself. Wearer related. Now, this is the point that I want to emphasize, that when prescribing contact lenses or when you come across a patient who's wearing contact lenses, one has to be very careful that they do not have a misunderstanding about the seriousness of wearing the lenses. Often you would have a patient who would come with some sort of foreign body sensation, have an infection, and then when you talk to them, you find that they've been very careless, they've been sleeping with the lenses on, and often they would not even be taking the care to wash or sterilize the lenses properly. And of course, there are pathological factors, various microorganisms which would adhere to the contact lens, the type of deposits, etc. These are becoming less common with the greater use of daily disposable lenses. Now, the checkpoints to evaluate when you see a patient, even if it's a minor problem the patient comes from, that time is an opportunity to counsel and make sure look after any other risk factors that the patient may have. A good history and baseline assessment. Also consider the design, the fit and the material, the contact lens care products. For example, a patient comes with infection. Don't forget to not only scrape the cornea, but also send the contact lens case and the contact lens and the solution for culture, and tell the patient to stop wearing contact lenses in the other eye till this is cleared. Regarding the signs and the symptoms, and it can also vary. The kind of manifestations would vary depending upon the type of the contact lens. And largely the complications could be considered as a microbial keratitis. There could be sometimes inflammatory keratitis and other metabolic conditions due to the altered metabolism of the epithelium, the stroma, the endothelium. There could be mechanical conditions due to wear and tear or rubbing or deposits, ptosis and discomfort. There could be toxic or allergic disorders, which often one would get with excessive use of soft contact lens wear, or if they have an underlying allergic eye disease such as VKC, tear resurfacing disorders, and dry eye and contact lens discomfort. So regarding the contact lens related problems, there is a whole host. I will not go step by step, but I would like to mention here bacterial keratitis, acanthamoeba keratitis, and fungal keratitis. You may find the patient is not that a patient with early keratitis, because of the comfort of the soft contact lens, they may not present so early because the contact lens protects them from the foreign body sensation, and it's when they remove the lens off in the evening and then they have that severe pain that they may land up in the emergency room. And of course, we can have giant papillary conjunctivitis, dry eye, ptosis, staining, edema, aggravation of allergy, and mucin. Regarding the RGP contact lenses, here sometimes the patients are wearing old lenses with lot of deposits, the fit may have changed, and you may find that there may be a surface, excessive surface bearing, so there may be an epithelial erosion or an abrasion, and if this is not taken care of at the proper time, the patient may have secondary microbial invasion and end up with a central microbial keratitis, which will lead to scarring and loss of vision. So if you have a patient who is complaining of some discomfort and you see the eye does not look to be anything much abnormal, do tell the patient to remove the contact lens and then re-examine. Look for the presence of any contact lens ring marks which indicate poor tear exchange, any staining indicative of lens touch, and poor fit can therefore also lead to corneal edema and staining. Regarding poor compliance to contact lens wear and follow-up, this may happen and the patient may be saying they're not comfortable with the contact lens, but that particular contact lens may be the best fit for that particular patient. Say if this is a case of early keratoconus. And initially they may have a lot of foreign body sensation wearing these RGP lenses. So there again, remove the lens, look carefully if it's really a question of no compliance or whether there is an abnormality of the fit. This is important because there are many patients who are, say, students or have exams, and they may not be a suitable candidate to go for keratoplasty straight away, but they can be given good vision with contact lenses and the proper fit at that particular point of time. Removing the contact lens, when you stain with the fluorescein, look at the pattern of staining, see how it's distributed in relation to the wearing of the lens on the eye. This is not very commonly seen, contact lens deposits, but you'll be surprised sometimes you do see these, and it's extremely important to show the patient and then tell them to discontinue the lens and improve their lens care regime. And progressive keratoconus, this is an example of a patient who had come 8 months after Rose K2 lens fitting, and this was a 24-year-old female who had been prescribed the Rose K2 lens for the keratoconus. After 6 months fitting, the patient seemed okay as far as the fitting was concerned. She did not complain of any discomfort or visual complaint, but when they come for follow-up, it's important to also remove the lens and recheck with the staining, and it actually was found that there were these deep impressions which were coming. So therefore, sometimes it depends upon the patient's threshold, and it's very important when you call them for follow-up, particularly at a disease like keratoconus where the cornea is not stable. It's going to change its physical characteristics, its curvature, etc. with time. It's extremely important to re-evaluate the patient every 6 months or so, and even the day that you fit the lenses, let the patient wear the lens in the clinic for an hour or so, and then recheck after that before you finally give the prescription. One example of a patient who had cross-linking done and was fitted with Scleral contact lenses. Here again, check the movement, check the stability, and look at the tear film after using the conventional soft contact lens after long hours. So this is the other thing that one needs to look at. Often they have software engineers who are wearing the soft contact lenses, and after several hours they are going to have this discomfort. In fact, a lot of people now are coming for refractive surgery because during the time of the COVID pandemic, they've realized that wearing the glasses was leading to fogging with their masks, and wearing contact lenses also was not very easy for them because during the lockdown period, they had difficulty accessing the solutions, etc. So a lot of patients are now discarding their contact lenses and coming for refractive surgery. Regarding complications of scleral lenses, this is a little difficult for patients. You have to take extra time teaching them for insertion, removal, application, difficulty with lens removal, surface non-wetting, surface depositions, and so on. There may be an air bubble. You have to explain to them properly how to fill up the lens with the solution and how to put it carefully. There could be inflammation and solution sensitivities. So these are all difficult cases. It's not an easy journey. And you have to do a lot of hand holding with the patient and give them time, and also call them for frequent follow-ups in the initial phases. Fitting challenges with scleral lenses, always remember to look. It may appear superficially as if it's a good fit, but if you do not look at the edge, you may miss the presence of the pinching, where there could actually be an indentation of the blood vessels, in which case there will be poor tear exchange, and this will lead to hypoxia and also neovascularization. So always look at the movement, look at the edge, look for excessive apical bearing, and there could be scleral impingement and blanching and sagging. So with that, I'll just show you one. Sometimes the patient may have a problem of a stuck scleral lens. This can be difficult, where you may have to put excessive lubricants and even retract the eyelids and help them remove the lens. There could be poor tear vault and deposits present over the lens. And then of course you could have contact lens associated red eye. Here again I would caution, if you see a patient, do not immediately start on topical steroids. Send a conjunctival swab in case there's an associated lingering infection. Give lubricants, discontinue the lenses and recheck, and even if you do have papillae, try lubricants and conservative measures, anti-allergic agents to begin with, and only then go for soft steroids if required. In the interest of time, I will not go over the rest of the cases, but I would like to emphasize again that contact lens related problems can be an issue. Microbial keratitis is a very serious complication which already is covered by the previous instruction course, but it's important that if a patient comes to you and has thrown away the contact lens, still you ask them to bring the case and the solution, and also of course you will scrape the cornea to find out the organism. With that I will stop. Thank you.
Thank you, ma'am, for the excellent talk. Now I would like